Hello, I'm Dr. Stephen Reed, and this is Dr. Scarcity and Suicides Post-Pandemic. The famous pediatric heart surgeon, Dr. Alfred Blalock, wrote, "It usually requires a considerable time to determine with certainty the virtues of a new method of treatment, and usually still longer to ascertain the harmful effects." I can think of no better description of the events of the last 4 years. During this interval, we've witnessed unprecedented disruption to the field of medicine. Like the grainy film reels of nuclear bomb tests or the horrifying cell phone photographs of the collapse of the World Trade Center, our impressions of the COVID pandemic are now fading into the shadows of history. But we're not in the clear. The pandemic and our responses to it continue to inescapably impact the present and foreseeably imperil the future. One such repercussion is an increase in healthcare worker suicides. Another is a massive shortage of doctors. We first need to come to grips with the fact that during the pandemic, many of our well-meaning experts' recommendations were unwarranted or harmful. Researchers now publish high-quality studies nearly every day, confirming our medical professionals provided advice detrimental to many patients. Already we're seeing spreading distrust of the pharmaceutical and healthcare industries. Families whose loved ones suffered harm or death from lockdowns or vaccine complications are seeking compensation, justice, and disturbingly, in some cases, vengeance. It's vital that we critically assess what went wrong, consolidate what we've learned, and anticipate how we can avoid future mishaps such as the foreseeable increase in healthcare worker suicidality and the impending doctor shortage. To get to the bottom of this, we must consider a difficult question. Why did doctors enthusiastically and collectively support the experimental mRNA vaccines when there was virtually no initial evidence of their long-term safety or efficacy? A few dissenters, such as those who signed the Great Barrington Declaration, expressed valid concerns early on. However, their voices were drowned out by the coordinated clamor of support for the vaccines from academia, the media, the government, pharmaceutical companies, and big tech. Skeptical caution was portrayed as selfishness. For example, "Your dangerous opinions are killing grandmothers." Doctors who questioned the dominant narrative were shunned and banned from medical journals and social media. Agencies extended substantial monetary incentives to physicians and healthcare institutions based on their percentage of their patient panels who received the injections. Frightening statistics appeared everywhere, with inflated COVID incidents and death counts dashboards on the internet and TV news chyrons. Doctors found their practices inundated with terrified patients, many of whom had serious illnesses in addition to COVID-19. Even worse, some patients canceled their doctor appointments out of fear of catching COVID, leaving their illnesses untreated. Publicly discussing potential vaccine complications was strictly taboo. Vaccines were shipped with totally blank product inserts instead of the usual cautions regarding possible adverse interactions and effects. Informed consent was insubstantial, if at all. Public service announcements showing people delighted and proud to get their vaccinations were mute on potential adverse reactions. Remarkably, they still are. I've yet to see an ad for the COVID vaccines listing adverse reactions. There's a classic joke in medical school. The student says, "This year's final exam is the same as the last year's." The instructor says, "Yes, but most of the answers are different now." And during the last 4 years, the answers became very, very different indeed. Before September 1, 2021, vaccines were defined as, quote, "inoculants that produce immunity to a specific disease." Now, vaccines are defined as preparations that are used to stimulate the body's immune response against diseases. Pre-pandemic virologists understood that leaky or non-sterilizing vaccines promoted the emergence of resistant viral variants. Later reporting this fact prompted even more doctors to get locked up in social media jail. Researchers formerly considered the VAERS database to be, quote, a valuable resource for monitoring adverse events from vaccines. Now it's, quote, self-reported anecdotal evidence. For thousands of years, physicians recognized good nutrition and fitness as mainstays of defense against diseases. During the pandemic, only the vaccines, monoclonal antibodies, steroids, ventilators, and remdesivir were promoted. Before the pandemic, it was widely acknowledged that surgical masks were ineffective in reducing transmission of aerosolized respiratory viruses. During the pandemic, masks were mandated nearly everywhere. Before COVID-19, virologists and physicians understood why systemically administered non-replicating vaccines perform poorly against mucosal respiratory viruses. Nevertheless, during the pandemic, they ignored established principles and wishfully promoted systemic genetic vaccines, which were predictably unlikely to prevent disease or disease transmission. Pre-pandemic, we understood quarantining healthy people served no purpose. It was obviously psychologically harmful and economically damaging. In the era of COVID-19, we were told the benefits of social isolation outweighed societal consequences. Behavioral psychology provides an explanation for why doctors uncritically supported the mRNA vaccines and lockdowns. Rewards and punishments, also known as carrots and sticks, reliably elicit desired behaviors. Throughout the pandemic, positive and negative incentives were imposed on physicians to mold their behaviors. Rewards for evangelizing vaccinations, masks, social distancing, and lockdowns included financial bonuses, meritorious quality indicators, prestige, favoritism on social media platforms, promotions in the workplace, and preferential editorial approval for articles submitted for publication. On the other hand, criticism of prevailing public health edicts resulted in harsh punishments, such as loss of referrals, excommunication from social media, automatic rejection of publications, ridicule, and ad hominem charges of selfishness, indifference, or ignorance. The most coercive punishments of all were those of loss of employment and threats to licensing. Our government guaranteed the producers of the vaccines immunity from liability, thereby burdening doctors and frontline healthcare professionals with legal culpability. Inevitably, some doctors became targets of malpractice lawsuits, with many more to come. Doctors now must cope with distrust, derision, and feelings of guilt and remorse. Doctors recognize their moral obligation to provide sound advice and safe and effective treatments to their patients. They usually critically evaluate new therapeutics before recommending them. This time, they had no time. Given the pressures of the pandemic, it's understandable why doctors deferred to the advice of the experts. Such naive acceptance may not have been the ideal decision, but given their time constraints and the overwhelming volume of information, it was rational. For example, physicians literally face impossible demands on their time. A recent study showed that primary care doctors need to work more than 26 hours each day to meet recommended guidelines for a typical patient panel. Anything less is considered a failure to meet important quality indicators. And that's not all. The body of medical knowledge doubles every 73 days. Doctors need to read 29 hours per weekday. That's right, 29 hours per weekday just to stay abreast of the current primary care literature. Throughout the pandemic, doctors simply didn't have the time or the background to personally research the new vaccines and public health measures. After all, most doctors aren't infectious disease specialists, and even those who are had no experience at all with mRNA vaccines outside of a few animal study labs. Physicians had to rely on the experts at the FDA and the CDC to perform due diligence and provide data-driven advice. Most doctors didn't realize the experts' recommendations were solely informed by limited data provided by the vaccine manufacturers. A recent Rasmussen poll of 1,000 U.S. adults showed that 49% believe it's likely that side effects of COVID-19 vaccines have caused a significant number of unexplained deaths. 28% said they personally know someone whose death they think may have been caused by side effects of COVID-19 vaccines. The point is, regardless of whether the vaccines actually pose a deadly threat, half of the population believes that they do. Some of the adverse events now confirmed to be directly linked to mRNA COVID vaccines include myocarditis, stroke, Bell's palsy, coagulation disorders, acute cardiac injuries, neuropathy, encephalitis, and sudden deaths. Other suspected adverse side effects include prion disease dementia, immunodeficiency, infertility, miscarriages, and accelerated progression of malignancies. As awareness of these adverse events grows, countless doctors are now struggling with a horrifying realization. What if some of my patients suffered harm or death from my actions? For all but psychopaths, such a realization is soul-shattering. I'll be discussing this later, but for now, please understand that a realization like this is one of the worst assaults on a doctor's sense of meaningful purpose that can happen. I've studied suicidality for decades, and I've come to an inescapable conclusion. In most cases of suicide, there is an intolerable discrepancy between the way in which the victim believes the world should be and the way in which it appears to actually be. Impossible time demands, legions of terrified patients, moral dilemmas, hostile workplaces, unavoidable liability, powerlessness, and overwhelming guilt all can be seen as intolerable discrepancies, and these can contribute to unbearable stress and doctor suicides. Most people have no idea of the scope of doctor suicides. About 1 million U.S. patients lose a doctor to suicide each year. Picture a typical U.S. medical exam room with a doctor and a patient seated inside. Before the pandemic, the doctor's risk of suicidal death was statistically twice as likely as that of the patient. It's probably worse now. Physician suicide rates significantly exceed those of active duty military and prison populations. Young physicians are especially susceptible. Suicide is the leading cause of death among male medical residents and the second leading cause of death among female residents after accidents. Doctors thrive best in environments where their knowledge, skills, and compassion can be put to use to improve the lives of their patients. These are the kinds of environments medical students expect to find when starting their training. Tragically, these environments are getting harder to find in today's commercialized and bureaucratic practice venues. Many doctors complain that most of their working hours involve data entry into electronic health records. The shift from private practice to physician employment over the last 3 decades deprived doctors of a great deal of personal agency. As we discussed earlier, powerful forces aligned to nudge doctors into giving advice in therapeutics that had no proven track record of safety or efficacy. Limited resources and directives beyond their control made doctors feel increasingly powerless to implement the best healthcare decisions during the pandemic. A recent study of 3,000 physicians investigated their incidence of symptoms of imposter phenomenon, also known as imposter syndrome, a psychological condition characterized by feelings that one is a fraud or not worthy of their achievements. It found that over a third had moderate symptoms, and an additional nearly 1/4 struggled with frequent or intense symptoms. Something's gone very wrong in our healthcare environment if almost 60% of physicians now feel like imposters. Doctors have experienced significant discrepancies between their concept of ideal medical practice and the actual situation in which they found themselves. For some, these discrepancies were intolerable. Like all human beings, doctors seek a meaning for their lives. Nietzsche wrote, quote, "He who has a why to live can bear almost any how. Many physicians find that will to meaning an irreplaceable foundation stone for their sense of self. Often to the consternation of their families, their profession becomes the central meaning of their life. If threatened, it can even overpower their will to live. Bear in mind that these doctors define themselves as healers, that they find their meaning in promoting health and relieving suffering, that knowing that you caused harm or death will absolutely devastate such a physician. A single death from vaccine-induced myocarditis could be the last straw, the crumbling of the foundation stone with collapse of the entire edifice. Enough to trigger a physician's suicide. A recent analysis examined U.S. physician mortality in the 22 months from March 2020 through December 2021. During this time, there were over 4,500 physician deaths, including 622 excess deaths compared to historical norms. How many of these excess deaths were suicide remains unknown. Before the pandemic, around 400 doctors, equivalent to a large medical school class, were lost to suicide every year. Too many doctors literally are dying, and this couldn't happen at a worse time. Many regions of the country now have no doctors. There are now nearly 100 million Americans living in, quote, medical care deserts who don't have ready access to a primary care physician. Countless heroic doctors and healthcare workers who risked their lives in the early pandemic lost their jobs because they declined the vaccines. A 2021 poll revealed that nearly 1 in 5 of U.S. healthcare workers quit their jobs since the start of the COVID pandemic. These included 117,000 physicians, over 53,000 nurse practitioners, and nearly 23,000 physician assistants. Internal medicine and family practice were the specialties most affected. In the recent hearing on the healthcare workforce crisis in America, Senator Bernie Sanders stressed, quote, according to the best estimates, over the next decade, our country faces a shortage of over 120,000 doctors, including a huge shortage of primary care doctors. The downward trend continues, with many doctors changing their careers or retiring early. Currently, over half of practicing doctors are 55 or older. A recent large survey involving more than 20,000 respondents found that nearly 1/4 of physicians reported they will likely leave their current practices within 2 years. The survey also found that about 1 in 3 doctors and other healthcare professionals indicated they intend to reduce work hours in the next year, further reducing access to health care. This brings us to an inevitable conclusion. The public's loss of trust in doctors is one of the tragic consequences of the COVID-19 pandemic. Talented, idealistic people who would have gone into medicine are now choosing other fields. For many practicing physicians, the intensification of accumulating stressors, the intolerable discrepancies are too much and will lead to early retirement or suicide. Indeed, for quite a few it already has. The end result is easily foreseeable. Sorry, there's no doctor for you. Organizations like the Lorna Breen Heroes Foundation and Dr. Lifeline recognize we must change practice environments to prevent healthcare workers' suicides. The next section of this presentation was produced in 2019, before the pandemic and before the formation of the Dr. Lorna Breen Heroes Foundation. It outlines the strategic plan proposed by Dr. Lifeline in 2019. We see opportunities to make positive changes at the levels of the individual doctor, doctors' families, institutions, and government. At the level of the individual doctor, we would like to offer helplines to offer immediate intervention and to provide confidential resources for discussing stressful issues. Ideally, we could serve as a source of referral for counseling, psychotherapy, possible psychiatric pharmacologic treatment, and interventions for acute and chronic post-traumatic stress disorder. We will provide advocacy for physicians suffering from burnout and learned helplessness. In order to assure privacy and confidentiality, we would encourage development of regional exchange programs to give the at-risk physicians the option to obtain counseling and treatment outside of their immediate communities. We would also provide human rights education in order to prevent abuse of physicians in training or those at the mercy of unsympathetic institutions. At the level of the physician's family, we will offer assistance with interventions. Understanding a burned-out doctor can be very bewildering for family members. We can provide education to family members regarding the stresses experienced by the at-risk physician and give them tips for helping the doctor to cope. Families may require counseling along with the doctor in order to optimize the home environment for recovery. The doctor's family members may require individual support, especially in the situation of a completed suicide. At the institutional level, Dr. Lifeline can help review policies to promote fairness and avoidance of abusive practices. We encourage institutions to develop a process for evaluating physicians' complaints without stigmatizing the physician. We hope to change institutional cultures to minimize workplace bullying and encourage physicians to seek help with stress, depression, and PTSD rather than suffer in silence. We can work with institutions to develop effective physician support systems. Poorly designed electronic health records are ubiquitous and currently frustrate and dishearten physicians at many institutions. Dr. Lifeline can offer advice to improve EHR design. We can offer institutions suggestions regarding assurance of confidentiality and assistance with external referrals. At the governmental level, we recommend the creation of a physician advisory board to assist well-meaning legislators and agencies in crafting legislation and regulations. We specifically wish to help them anticipate and avoid unintended consequences which add to the physician's burden and further toxify the practice environment. We wish to encourage further funding for research, intervention, and treatment programs directed at the prevention of physician suicide. We believe the government has a responsibility for investigation of serious complaints and enforcement mechanisms to facilitate a safe, non-hostile healthcare workplace environment. Fulfilling this responsibility may require a specific healthcare workplace initiative. We recommend review of state medical license board practices to minimize physicians' concerns that seeking help for depression could stigmatize the doctor and jeopardize licensing. For more on these topics, please see the Lorna Breen Heroes Foundation at drlornabreen.org and Dr. Lifeline at drlifeline.org.